Thank you very much. Good afternoon, good morning, and good evening for some of you. Thank you for joining us. Again, I would like to thank Johns Hopkins University and the University of, I think, Ghana for arranging this session. Today's presentation will be interpretation of ABG. So how to read ABG will be dealt by Dr. Moses. Dr. Moses is a senior specialist. He's an intensivist, anesthesiologist, and as the director of anesthesia and intensive care of the Ghanaian Komfo Anokye Teaching Hospital in Ghana. He is the head of intensive care unit of the hospital. He is a trainer for a resident program in anesthesia and intensive care for both the Ghana College of Physicians and Surgeons, and he is a West African College of Surgeon approved, and he is a member of the Global Health and Infectious Disease Group of the college, and he is a fellow working on the Ghana ICU registry. He is a recent past lecturer in anesthesiology, intensive care at the Ghana Kwame Nkrumah University of Science and Technology in Ghana. He is the General Secretary of the Ghana Anesthesiology Society, a founding member of the Critical Care Society of the Ghana. And his area of interests are studying sepsis, hemodynamic assessment, ultrasound, mechanical ventilator, all related to critical care. He has ample experience in critical care, so he is the right person for today's session. Thank you a lot, Dr. Moses, for taking time to do this presentation. And thank you, everyone. We will have a good time. We will have a 45-minute presentation, and we will have question and answer. You can drop your question in the chat box. We will try to respond to all your questions. Thank you very much, and back to you, Dr. Moses. Thank you. Yes.
Okay, so today, like was said, we are doing ABG interpretation. So, and then I have no conflict of interest to declare. So our learning objectives will be to appreciate the component of an arterial blood gas report, analyze the respiratory and metabolic derangements, and then also determine complex acid-base disorders. So this will be the order of my presentation. Some brief introduction. We'll look at the analysis, markers of perfusion, market of acid-base derangement, and then we'll conclude. So by way of introduction, there's a pH range that is compatible with life, and generally 6.8 to 7.8. Some even state 6.9, 6.9 to 7.9, but usually around this range. Then below, outside this range, then life cannot progress. And then most biological fluids are alkaline. Okay, even though we say that that is a neutral, it's more alkaline if you look at absolute pH terms. And then note that intracellular compartment is more acidic than extracellular compartment. But very often what we deal with on daily basis is the extracellular compartment. So why do we need a constant ABG, and why is it that, a constant pH? And why is it that every now and then, especially in the intensive care, we are striving to make sure that the derangement in the pH is not too much? Because it affects dissociation of substances and electrolytes. And then you need it to keep intracellular ions ionized so that they stay within reasonable concentrations. And then you need a constant pH range for effective metabolic reactions, especially when you want optimal enzymatic functions. Then you need the pH to be constant over a long period. Outside the range, enzymatic reactions are potentially impaired, and metabolic processes to get impaired and it affects life. So when will you do an ABG? Usually in a hypoxic state or any shock state when you have ventilatory failure or any respiratory failure, and then sometimes to also gauge the metabolic activities. When you take an ABG, I want to stress that it is not only acid-base status parameters that are on it. And very often when we pick an ABG report, we sometimes neglect the other one. So I'll just highlight the various parameters that are displayed on the ABG and what they gauge so that it draws our attention to them as we interpret. So we'll take that out of our way and then we'll now focus on the acid-base analysis itself. But just to emphasize that aside acid-base status, it gives you a report on the respiratory gases, and then you can gauge markers of oxygenation, assess perfusion states, and then you also get electrolyte reports on a typical modern ABG. Now, not all the parameters that you see on the report are directly measured. Some are calculated. So the directly measured ones are the pH, PO2, PCO2, lactate, electrolytes, and then the indirect ones, which are calculated are the base SS, bicarbonate, anion gap. So when you are interpreting the ABG, especially the gases, you first want to know if your PO2 is adequate. And for your PO2 to be adequate, you always have to compare it to the partial pressure of oxygen that you are delivering to the patient. Typically, we say that a normal PO2 should be 3 to 5 times the FiO2 that you are giving. Then again, you should remember the impact of the other gases, especially carbon dioxide on the PO2. Per the alveolar gas equation, when you have a very low PCO2, it will lead to a higher PO2 just because there's some form of hyperventilation and vice versa. So when you are interpreting what is a normal PO2, also look at the level of PCO2. And then you also are able to get the AA gradient, the difference between the alveolar partial pressure of oxygen and arteriolar partial pressure of oxygen. That gradient tells you how effective diffusion is. So it's one of the markers of oxygenation. Okay. And then when you have a normal AA gradient, most often tells you that maybe diffusion is not a problem, but maybe other factors such as hypoventilation and low PO2. Equally, when you have an impaired or prolonged AA gradient, then most often you are dealing with some shunting, diffusion defects, or VQ mismatches. So what are the markers of perfusion on the ABG? So we have lactate report on it. And then the SaO2 of venous blood, especially when you've taken superior vena cava sample and you're able to measure the SaO2 on that sample, then it's a surrogate for mixed venous oxygen saturation, which is also a marker of adequacy of oxygen delivery. And then sometimes you may also look at the anion gap, especially when you have lactate rising, you may have widening of the anion gap. Then there are some electrolytes that you can also get on a typical ABG. Okay, so we've taken that out of our way just to highlight that, like I said at the beginning, it is not acid-base status alone that is on a typical ABG report. So let's spend some time on the acid-base status itself. Generally, there are two components. when it comes to the acid-base status, we are looking at the respiratory component and then the metabolic component. The overall pH status of the body is a sum of the effect of these two arms. So the combined effect of respiratory status and metabolic status gives the overall pH status of the body. There are some terminologies that we should take note, especially as we journey through ABG interpretation, that the overall pH derangement takes the EMEA terminology. So if you have a pH in acidotic range, you say you are doing, you have acidemia. Equally, if the overall pH is in the alkalotic range, then you say you have alkalemia. Now, we've said that there are two different arms contributing to the overall pH, which is the respiratory arm and metabolic arm. When you have derangement in any of the arms, then you use the OSIS terminology. So you can have respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis, but the combined effect will be EMEA. Then there are some things that you need to, you see on the ABG, you see actual bicarbonate, standard bicarbonate, base SS, standard base SS. Sometimes you are wondering which one to use. So the actual base SS is what is calculated, but we know that PCO2 affects the level of bicarbonate. So when you have a very high PCO2, naturally you have a higher bicarbonate, and the reverse is also true. So when you have corrected the bicarbonate, the effect of the PCO2 on the bicarbonate, then you have the standard. So most often you should gravitate towards using the standard. Equally, we know that variations in HB affects base SS calculation, but it is standardized to, when it is calculated absolutely, they have just the base SS, but when it is standardized to an HB of 5 grams per deciliter, then you have the standard base SS. Again, it is good to use that more than the base SS, just the base SS. So let's look at what a normal ABG should look like. The pH range should be 7.35, 7.45. Some say 7.34 to 7.44. It's around the same. The PCO2 should be between 35 to 45, bicarbonate 22 to 26, and then base SS plus or minus 2. Some say plus or minus 3. And then the anion gap, it varies based on the ABG, the scope of electrolytes that you're able to measure. But generally, people state it around 8 plus or minus 4. So what are the steps in analyzing the acid-base status? The first is to look at the overall pH to determine whether it is acidemia or alkalemia. The next is to find out which arm, whether respiratory or metabolic, explains the overall pH. That will help you to determine what the primary disorder is. Then you need to determine if compensation has started or not. So let's look at a few examples. So the first is to look at the overall pH. So if you look at this column, that of Adjoa, the first column, the overall pH is 7.05, which suggests that it is acidemia, because we said the normal is 7.35, 7.45. Okay. The next is to find out which of the two arms explains the overall pH. So you look at the PCO2, we said the normal is 35 to 45. This is high, and PCO2 is an acidic gas. When you have high, you have acidity. So the respiratory arm is in acidosis range, and that explains the overall pH. Okay, so it's likely to be a primary problem. Let's look at the bicarbonate. 22 to 26, 30 is high, it's in the alkalotic range, it doesn't explain the overall pH. So we say that this is alkalemia and it is respiratory acidosis mainly contributing to that. Now, whenever you have derangement in one arm, there's opposite, the other arm moves in the opposite direction by way of compensation. So this is respiratory acidosis. To know whether there's compensation or not, you look at the metabolic arm, which is reflected by bicarbonate. It is in the alkalotic range. So it is opposing the respiratory. So the primary problem is respiratory and compensation has started. If you take coffee, the overall pH is 7.7, which is alkalemia. Now, respiratory is 36. It's normal. So it doesn't explain the overall pH. It's not the primary problem. But if you look at the bicarbonate, it is 35. It's in alkalosis, metabolic alkalosis, and that explains the overall pH. So you say that this patient has primary metabolic alkalosis, but compensation has not started because the PCO2 is not moving in the opposite direction. Let's look at James. For James, the pH is normal, but the PCO2 is alkalosis, is less than 35. The bicarbonate is in acidosis. So sometimes you have pictures like this where the overall pH looks normal, but there's opposing derangement in the arms. Okay. Do not rejoice when you have a normal pH. Rejoice when you have normal pH and the arms too are normal. So even though this overall pH is normal, it doesn't make us comfortable because there's metabolic acidosis, metabolic respiratory alkalosis all going on. Then let's look at the twins. You are having a pH of 7.22, okay, which is in acidosis. Respiratory is more than 45. So you have respiratory acidosis. That explains the overall pH. So it is likely to be a primary problem. But if you look at the metabolic too, there is acidosis because it is less than 22. Okay, so both respiratory and metabolic explain the overall pH. So this is a mixed disorder. So when you have the metabolic arm and the respiratory arm both explaining the overall pH, you say you have a mixed disorder. Then let's look at this, the last one, Ama, who has a pH of 7.6, which is alkalemia. If you look at PCO2, it is high, which is acidosis. It doesn't explain the overall pH, so it's not the primary problem. But if you look at the metabolic arm, it is alkalosis. It explains the overall pH. So for this, we'll say that the patient has metabolic alkalosis respiratory compensation because it's moving in the opposite direction. So those are the steps that we go to in interpreting the ABG. Now, let's look at controversies. So generally, respiratory derangements are not difficult to analyze and also quantify. It's just the PCO2. Whenever PCO2 is going up, it's acidosis. When it's going down, it's alkalosis. And again, the quantum determines the severity. So if it is very high, most often is a very severe form. If it is low, it is so. But the challenge has been the metabolic component. It is a little complex and not straightforward because what we use to gauge it, which is the bicarbonate, is not an independent variable. Okay, and it has a lot of things influencing it. And then again, the extent of derangement do not always reflect the extent of its severity. So there's been a lot of schools of thought when it comes to bicarbonate. the metabolic arm, so that we have a set of rules that will be applicable no matter the derangement. Okay. Then the other challenge we have too is that sometimes you bring a rule that will explain maybe a metabolic acidosis, but that same set of rules will not help you properly analyze and explain or classify metabolic alkalosis. A typical example is when it comes to metabolic acidosis, you say we have high anion gap metabolic acidosis or normal anion gap metabolic acidosis. So you are using anion gap to classify the types of metabolic acidosis. However, anion gap is not applicable in alkalosis. Do you get? So one struggle is that we are not getting one parameter that can give us a good reflection across board. So because of that, there have been proponents who have brought a set of rules to attempt to better explain the metabolic derangement, but none is perfect. The Copenhagen school is looking at derangement in the bicarbonate to gauge the extent of derangement and the type of derangement. Then when they were having issues, then they introduced the concept of base excess or base deficit, depending on which part of the globe you are coming from, to also determine the extent of deviation from the norm. It helped, okay? But Boston School too is arguing that this bicarbonate that you are stressing yourself on is not a dependent, it's not an independent variable. It has things that influence it. That is one. PCO2 is a typical example. Again, what is normal bicarbonate to will depend on whether the derangement in respiratory arm is acute or chronic. The extent of derangement or the changes that occur are different, whether it is acute or chronic. Okay, so Copenhagen brings a set of rules that looks at the changes in bicarbonate in different scenarios. It also helps. Okay, so very, very often when we are doing interpretation, holistic interpretation, we take portions of different schools to put them together. Okay. Now, in the ICU in particular, in critical care, one challenge we have is that you have a lot of patients who have more than one acid-base disorder. If it were just a simple respiratory acidosis, nothing more, fine, or respiratory alkalosis alone, metabolic acidosis alone, metabolic alkalosis alone. But very often, you have one or two combinations at play. The challenge is that if you don't try to find out all the existing derangements at the time of your assessment and dwell on the obvious one, once you've managed it, the other ones begin to rear their heads, okay? Then you pick them one after the other. But it is possible to determine all the possible acid-base derangements at the time that you are seeing, okay, so that you tackle all of them at a go. How do you do that? We do that mainly by using some set of rules, but they generally look at the adequacy of the compensation that is taking place to be able to gauge whether there exist other acid-base disorders. Let's look at some of them. What are the compensations for respiratory disorders? So you have a primary respiratory disorder. You want to know whether there exist metabolic disorders. What you find out is this respiratory disorder that I'm having, is it acute or chronic? Is it respiratory or alkalosis? for each description, there's an expected change in the bicarbonate per every 10. Okay, so if you look at respiratory acidosis, in the acute state, a change in 10 should cause a change in bicarbonate by 1. So that when you have the change more than or less than this, it tells you that another acid-base disorder exists. If it is chronic, then it should change, a change in PCO2 by 10 should cause a change in bicarbonate of 4. If this is acidosis to alkalosis, it's not the same. Acute, per every 10, you expect 2. If it's chronic, per every 10, you expect 5. So that if somebody has a chronic respiratory alkalosis, then you expect the compensation in the metabolic arm to be in acidosis. So all things being equal, if the PCO2 increased by or decreased by 10, you expect a decrease in the bicarbonate by 5. If, for instance, you have a decrease more than 5, let's say about 8, then there's another acid-base disorder contributing to the excessive decline. Okay, so in this case, you say that there exists a metabolic acidosis as well, in addition to the metabolic alkalosis. Because if it is alkalosis alone, the compensation should let it decrease by 5. So that's how you assess adequacy of compensation for respiratory derangement. What about metabolic derangement? For metabolic acidosis, the expected PCO2 is calculated by the formula that I've shown. 1.5 times the measured bicarbonate plus 8 plus or minus 2. So for instance, assuming you have a metabolic acidosis and the bicarbonate is 10, then 10 times 1.5 will be 15. 15 plus 8 is 23. Okay, so 23 plus or minus 2. So the range of PCO2 appropriate for a metabolic acidosis with bicarbonate of 10 will be 21 to 25 because it was 23 plus or minus 2. Anything outside this range, it tells you that another acid-base derangement is there. So for instance, if you calculated, we said it has to be 21 to 23, and you got the PCO2 that you got is, let's say 30. Okay. It tells you that there's something adding, another derangement is adding more PCO2, and that's acidosis. So there exists a respiratory acidosis in addition to the metabolic acidosis. If for this same calculation, the PCO2, for instance, is 15, we know the lower range should have been 21. Then there's another process further decreasing the PCO2 beyond what it has to be. And that would be a respiratory alkalosis in addition to the metabolic acidosis. When it comes to the metabolic alkalosis, there's the formula, and the principles and interpretation are similar to what I've done for the respiratory acidosis. Then there's this delta factor or delta gap. Okay, it works on the assumption that if an acid-base derangement is leading to a unitary change in the bicarbonate, it should lead to a unitary change in, a unitary change in the anion gap. Then there should be a unitary change in the bicarbonate as well. So if you have, let's say, your normal anion gap, you say it is, let's say, 11. That is your normal. Then you do the anion gap. It is 18. It is 7 more than your 11. Okay. So anion gap has changed by 7. You expect the bicarbonate to decrease by 7. When you have a similar decrease, then you say that the metabolic acidosis is fully explained by the high anion gap metabolic acidosis. But when you have the example I've given, let's see, for the bicarbonate, for anion gap of 18, the change, and we are saying our normal is 11, the change is 7. So you expect the bicarbonate to be 24 minus 7, which will be 17. If it is 17, then it means that the anion gap, high anion gap, is fully explaining the metabolic derangement. But if, for instance, the bicarbonate is 10, then it cannot be fully explained by the change in anion gap. The anion gap has decreased it by 7, from 24 to 17. But there's another process which is further decreasing it from the 17 to 10. So once you have such a case, then you say that there exists normal anion gap metabolic acidosis in addition to the high anion gap metabolic acidosis. Or let's say this same example, the change is 7. You would expect that the bicarbonate is 24 minus 7, which is 17. But the measured bicarbonate is 21. Okay, so there's another derangement adding more bicarbonate, so to speak, to the system. That is what is elevating the bicarbonate beyond the expected. So then you conclude that this patient has normal high anion gap metabolic acidosis, but also has metabolic alkalosis as well. Okay, so that is how you use the delta gap. So the delta gap helps us, especially when you have metabolic derangement, metabolic acidosis. It helps you determine whether you have a single metabolic acidosis derangement or both exist. When I say both, I mean the high anion gap and normal anion gap. Use the delta factor or the delta gap. Now, another school, another concept, which is the Stewart's approach, and it's quite a little radical, different concepts. Okay, so if you look at the other, if you say high anion gap metabolic acidosis, the traditional teaching has been that once you have that, then it means there's a titratable acid in the system causing a derangement in the pH. So you say there's lactate in the system, so that has reduced the pH, or there's ketone acids in the system. Okay. Now, Stewart is saying that man, and for that matter, woman, is predominantly water. And if you look at the water, the predominant molecule in water is hydrogen. Stewart is saying that there's so much hydrogen in the body such that exogenous, or you need a very high introduction of H+ into the body to cause derangement. He is arguing that whether you are acidotic or alkalosis depends on the extent of the dissociation of the water molecules that you have in your body, not any exogenous or extraneous acid or base being added to it. Okay, so he starts by saying that when you talk about solutes in the plasma, you can say that you have electrolytes and non-electrolytes. That's the first classification. Okay, so non-electrolytes don't really contribute much. Then electrolytes, you can have two categories. We have strong ions and weak ions. If you come to strong ions, so strong ions are ions that dissociate completely in water. If you take sodium chloride, for instance, sodium chloride will dissociate completely in water into sodium ions and chloride ions. Such electrolytes are called strong ions. Then those that dissociate partially or incompletely are the weak ions. Under weak ions, you have the volatile acids. A typical example will be CO2, and non-volatile acids, where you talk about albumin and phosphates. Then when you talk about strong ions, you have strong cations, which are sodium, potassium. Then you have strong anions, lactate and CO2. Okay, so Stewart is saying that it is these electrolytes, the dissociation of these electrolytes, or in solution, alters the extent of water dissociation, and the extent will determine the acid-base status. So Stewart is saying that there are only 3 independent parameters contributing to the acid-base status. You see, the traditional approach even suggests that bicarbonate is an independent variable. So it gauges the metabolic. If you want to diagnose metabolic acidosis, it depends on whether the bicarbonate is low or high. Okay, metabolic derangement. But we also know that, and even and that's why the Copenhagen School tried to bring other caveats to further streamline things, because we even know that the extent of PCO2 affect the bicarbonate. So bicarbonate is not an independent determinant of acid-base status. But Stewart is saying that there are only 3 independent variables. You are looking at the partial pressure of carbon dioxide, PaCO2, strong ion difference, and the concentration of non-volatile weak acids in the blood. These are the 3 independent. So if you say strong ion difference, it is the difference between all the strong ions and all the strong cations. And in the body, the strongest cation, predominant strongest cation is what? Sodium. The strongest and most abundant in the body is chloride. Okay. And even if you take the normal, sodium to be 140 something and the chloride to be 100, then there exists a gap between the strong ions. And so we say the normal strong ion is around 40 to 42. You say a patient has acidosis when the strong ion difference is narrowed. So if you calculate the strong ion difference and it's 30, the normal is 40 to 42, then it is acidosis. If it is high, it's alkalosis. Okay. So the Stewart approach focuses on the the metabolic arm. It does not explain everything in total, but it makes us better understand certain concepts. Okay. For instance, how much derangement, or what will be the effect of the infusion of 1 liter of normal saline on the pH? We all know that we've been told that normal saline infusion leads to metabolic acidosis. But the traditional approach can't explain how this causes metabolic acidosis. But if you want to just do a calculation, we know that normal saline contains 154 millimole of sodium per liter. And it also contains 154 millimoles of chloride per liter. It is 154, 154. So if you take sodium chloride, the strong ion difference is 0, because the strong cation is 154, the strong anion is 154. The difference is 0. So it is an acidic solution. When you've infused it into the body, if you take the normal body sodium to be 140, okay, and the chloride to be 100, and the blood in the person's the effective blood in circulation is 5 liters. Assuming you added 1 liter of 154, you can calculate the new concentration of sodium, and you see that it will be slightly higher than 140. But because chloride in the system is 100, for instance, and you're adding 154, the increase in chloride is higher than the increase in the sodium. So the new SID will be less than 40, and that will be the acidosis. So the Stewart approach makes more clinical sense, and you can actually use the concept of Stewart approach to look at the effect of all your solutions on the pH. And even if you wish to give a cocktail or combination of infusions that will not alter the pH, you could actually do combinations of fluid, the electrolytes and bicarbonate constituted such that it doesn't increase the overall pH. So really, no one school or concept explains everything. You need a combination of all of them. Let's take the following home, that ABG gives a lot of information. I've told you that not acid-base status, and then be meticulous in the analysis so that you don't miss other existing. There are always the obvious ones and there are the hidden ones. But when you are meticulous, you pick everything. But very often, I mean, we have joy in establishing the diagnosis of the derangement, maybe metabolic alkalosis. What is the management? It becomes an issue. But after diagnosing, you manage the patient as well. This is my bibliography. And good afternoon, good morning, good evening, wherever you are. And then thanks for coming.